Bismillahirrahmanirrahim. Today we will have case quiz number 34. Case data: 45 years old female presented by generalized bone pain and difficulty in walking. She denies localized joint pain but hurts all over, and she finds it hard to get out of chair or climb the stairs and walk with a waddling gait. Symptoms have been getting progressively worse for around 1 year. She is otherwise well. So, to summarize the symptoms: generalized bone pain and difficulty walking. There is no localized joint pain, but generalized bone pain with difficulty to walking, to climb stairs, to get out of chair. By examination, there is no peripheral stigmata of inflammatory disease. Bone rather than joint tenderness with mild proximal weakness. The remainder of the examination is within normal. The investigation showed ESR normal, CRB normal, CBK normal, calcium low, alkaline phosphatase high, vitamin D low, and parathormone high. So, what is the diagnosis? The answer is, it is easy today. The answer is osteomalacia. What is osteomalacia? Osteomalacia: this patient has a combination of bone pain and proximal myopathy. The normal CBK suggests that it is not a primary muscle disorder, and the biochemical picture of low vitamin D and high parathormone suggests vitamin D deficiency. The diagnosis of osteomalacia: a condition of poor mineralization of bone and excessive osteoid. The symptoms of osteomalacia can be very vague, and the condition must be specifically considered to avoid missing the diagnosis. These are some features of osteomalacia and rickets. Rickets is the loss of mineralization in children, but osteomalacia is the loss of mineralization in adulthood and in old age. These are features of both osteomalacia and rickets, including bone pain and tenderness, proximal myopathy, paresthesia or tetany, and on radiology we may have loser zone osteomalacia, and biochemistry: low vitamin D, low or normal calcium, with high alkaline phosphatase and parathormone. Some features are occurring only in rickets, including deformity. Deformity is not common in osteomalacia because the development of the patient already completed. The causes of osteomalacia include low vitamin D due to lack of sun exposure or poor oral intake, malabsorption due to celiac disease, gastrectomy, or pancreatic insufficiency, renal disease due to renal osteodystrophy, hypophosphatemic renal disease, Fanconi syndrome, or renal tubular acidosis, and may be due to drugs such as anticonvulsant such as phenytoin and carbamazepine. However, the differential diagnosis of osteomalacia is very wide, very extensive, and may include fibromyalgia, osteoporosis, polymyalgia rheumatica, polymyositis, rheumatoid arthritis, multiple myeloma, metastatic bone disease, or generally any case with generalized bone and joint pain may be missed or may have similar picture to osteomalacia. Here, the lack of inflammatory response and normal CBK is therefore very reassuring in the assessment of patients with possible osteomalacia. Management of osteomalacia focus on patient education. Only minimal sun exposure, at least 15 minutes to sunshine or to face and hands and arms, is required to maintain vitamin D levels, although those with darker skin may require longer exposure. Oily fish and certain supplemented cereals should be included in the diet wherever possible, but frank vitamin D deficiency is treated with vitamin D supplementation. Mild deficiency is treated with 800 International Unit vitamin D daily, but more severe deficiency may require higher doses of oral bolus followed by standard daily doses. All patients with vitamin D supplementation should also receive additional calcium even if the serum calcium is within normal. And finally, thank you very much for your attendance and see you tomorrow with case quiz number 35. Wassalamu alaikum wa rahmatullahi wa barakatuh.